Welcome to the Town and Country Compounding Podcast, where we delve into the heart of personalized healthcare and explore the transformative role of compounding pharmacies. I'm your host, Steve, Director of Strategic Partnership here at Town and Country Compounding. Today, I'm thrilled to welcome a guest who's not just a leading voice in the compounding industry, but also a champion for regulatory clarity and patient access. Joining us is Scott Brunner, Chief Executive Officer of the Alliance for Pharmacy Compounding, or APC. Scott, thank you for being here. Dive into all the nerd knitting golden stuff with compounding. Could you give our listeners a brief overview of APC's mission and your role in advocating for the compounding industry?
Yeah, happy to. And thanks, Steve, for having me. These are interesting times for compounding, and I'm sure we'll discuss why that might be so. APC, the Alliance for Pharmacy Compounding, is the industry trade association. Our members are compounding pharmacists and technicians, supply chain professionals, marketers, even prescribers, regulators, and a few patients. We represent about 600 small businesses across the U.S., and our individual memberships number in around 5,000 or so. And our sweet spot is advocacy. We advocate on behalf of the patients who are served by compounded medications, and certainly on behalf of the pharmacies and outsourcing facilities that prepare those drugs.
Got it. Thank you for that. Thank you. It's amazing what you guys do. I think of like APHA, ASHP, but for compounding, there's no better professional organization than yours. So I really appreciate it. You gave your perspective in an article recently titled Perspective, Eli Lilly's Intervention and FDA's Lawsuit against FDA. Can you please give our listeners your perspective of this high level? We'll give them the link to the article. They'll probably pop up over here somewhere. But yeah, what's your perspective on it?
Yeah. Knowing where to start is probably a difficult thing. I presume that your listeners know that both tirzepatide and semaglutide, the active pharmaceutical ingredient in these blockbuster GLP-1 drugs, have been in shortage for a protracted period of time. Semaglutide since March of 2022, and up until December, tirzepatide had been in shortage since December of 2022, so 2 years. FDA declared last fall that the tirzepatide shortage was resolved. That immediately resulted in a lawsuit by OFA, one of our sister associations, the Outsourcing Facilities Association. And OFA asserted that FDA had been cavalier and arbitrary in ending the tirzepatide shortage, that it had relied on incomplete, at best, data, and that the agency should have gone through notice and comment rulemaking to determine that that shortage was resolved. Within days of OFA filing that lawsuit, FDA came back and said to the court, give us a chance to reconsider this, remand it back to us, and give us a period of time when we can reconsider that decision. That alone is fairly extraordinary, that the agency would preemptively, before the court has read any briefs, taken any action, ask the court to remand it. The court agreed. FDA was given 60 days. The 60 days turned into 90 days with the agreement of OFA and the court. And December 19th sort of became the drop dead date, where FDA was to come back to the court and either say, oh, we were wrong and the shortage is not resolved, or they could double down on that decision. Well, on December 19th, they doubled down. They said, indeed, the tirzepatide shortage is resolved, and they stipulated a 60-day window in which traditional compounding pharmacies could continue to prepare copies of the FDA-approved tirzepatide injectables, while pharmacies, really that 60 days was to give pharmacies time to transition the patients from the compounded version of the drug to the FDA-approved drug. It was to make sure that there would not be interruptions of that therapy. FDA also indicated that it would give 503B outsourcing facilities 90 days to continue to distribute those drugs before they had to stop. Well, that was all well and good, I guess. We have our disagreements with FDA about whether the tirzepatide shortage is actually resolved. We continue to hear from pharmacies across the country that they are having difficulties getting the FDA-approved Mounjaro or bound in quantities they need to transition their patients. And yet, FDA did what it did, and pharmacies are bound to comply with that. Interestingly, that was on December 19th. January 1st, Eli Lilly files a motion with a brief, I guess, with the court to intervene, to in effect become a third party in this dispute between OFA and FDA. The court granted that request for intervention, and what Eli Lilly's doing is really interesting. I think they're doing, there's a political motive, but also a legal motive, and both of them think are interesting. The political motive is that we're in this period where in the next 3 weeks we're going to have a new presidential administration. Shortly after that, we're going to have a new HHS secretary that may be Robert F. Kennedy Jr. if he is confirmed. We will have a new FDA commissioner, Dr. McCary, again if he is confirmed. And I think Eli Lilly, in joining this lawsuit, is trying to hedge against the possibility that these Trump administration officials will reverse what FDA has said in terms of the resolution of the short. I personally think it's unlikely that they're going to do that, but it is possible that they would do that. And so Eli Lilly wants to preserve its ability to make certain claims in court should FDA fold. And so if FDA bows out, reinstates the shortage, there will still be a lawsuit between OSA, but it will be Lilly as the main other party in the case. So that's the political motive. The interesting thing Lilly is doing, and their brief again and again talks about their financial interest, which I think is interesting. It's not so much about patients and access; it's about Lilly's financial interest. Yeah, go figure. But they do make one claim that is extraordinarily concerning, and that is they are claiming they are alleging in their brief that FDA does not have the statutory authority to determine when compounding pharmacies can make copies of FDA approved drugs. So a little bit of background. I'm sorry if this is too nerdy, but
Exactly how nerdy we want it.
okay, good. Well, FDA guidance has long allowed traditional compounding pharmacies to make copies of FDA approved drugs when an FDA approved drug is listed as currently in shortage on the FDA drug shortage list. Any other time, compounding pharmacies can't make copies of FDA approved drugs. Compounding pharmacy is not going to be able to make a range of drugs that are prescribed daily if the drugs are not in shortage.
Right.
The reason for FDA allowing that in guidance is continuation of patient care. I mean, just because a drug maker can't meet demand for the drug doesn't mean that patients don't need it. And many of these are essential therapies that patients' health would be at great risk if there was an interruption of that therapy. And so, relying on that guidance, compounding pharmacies for the past 3 years with semaglutide, the past 2 years with tirzepatide, have been preparing copies of the FDA approved drugs. Well, Lilly in this suit is saying FDA's gotten it wrong and they do not have the authority to do that because the statute, the Food, Drug, and Cosmetic Act, does not say that inclusion on the drug shortage list is a condition under which 503A traditional compounding pharmacies can prepare copies. And if that claim were given credence by the court, if the court were to agree, it would completely wipe out the ability of traditional compounding pharmacies to fill gaps in the drug supply chain when a drug is in shortage. And that would be darn near catastrophic. Now, when we read the Food, Drug, and Cosmetic Act, we think Lilly's lawyers have gotten it egregiously wrong because the statute specifically delegates to the HHS secretary the ability to determine what circumstances under which compounding pharmacies can make copies of FDA approved drugs in quote regular or inordinate amounts. I think it says regularly or in inordinate amounts. So we have a specific delegation of authority to the HHS commissioner to do that. And the HHS commissioner has done that through the FDA and this guidance document. And so a lot is at stake. if FDA, this could be a red herring, but if FDA is serious, sorry, if Lilly is serious about pursuing this claim, the implications go well beyond GLP-1 drugs to a range of therapies that compounding pharmacies provide for patients when the FDA-approved drug is in shortage. And I promise I'll come up for air in a second. One recent example, and it's an important example, is in the fall and winter of 2022-23, when amoxicillin suspension was in shortage. We had children sick with RSV and some other things, and parents were frantic and prescribers were frustrated because they couldn't get amoxicillin suspension for their patients because it was in shortage. Compounding pharmacies, under this FDA guidance, stepped in and filled that gap until the drug could come back into supply. And I guarantee you, children's lives were saved because of that. That's just one example among thousands of where this guidance is necessary. And so we think Eli Lilly's a bit of a bull under China shop in taking aim at that particular provision of the Food, Drug, and Cosmetic Act and trying to undercut FDA guidance. So the stakes are high.
Yeah, they may be actually like shooting themselves in the foot because it would like further, it could potentially cause the whole system to further solidify and make the shortage process even better because they're trying to push against it. It- yeah.
Well, the interesting thing that's going on in terms of the tirzepatide shortage in particular, we do think Eli Lilly relied on incomplete data. The problem with compounding is that we are data poor. I can't tell you how many prescriptions for semaglutide injection Town and Country has filled, or a pharmacy across the country, or any other pharmacy. And so when reporters and regulators and members of Congress call and want some numbers, we just don't have those. One of the reasons for that is, as you know, compounding is a cash-only business. Insurance, generally speaking, there are exceptions, will not reimburse for compounded drugs. And so there's no central database where you can figure out how many reimbursements were made and estimate from that how many patients are taking a compounded version of an X, Y, or Z. And so when FDA took Lilly's data, it was only looking at Lilly data. It was not looking at the number of patients who were on the compounded version of the drug who needed to be transitioned to the FDA approved versions of Fixes. And so what I think is possible, I don't know if it's likely, I think it's possible, but I think as pharmacies begin to try to transition these patients to who were taking the compounded drug over to the FDA approved Mounjaro or Zepbound, it has the potential to knock the FDA approved drug back into shortage because nobody was thinking about how big the demand was for these patients who were taking the compounded version. One thing that might undercut that is prescribers who are not transitioning their patient from compounded tirzepatide injection to Mounjaro or Zepbound, but are transitioning them to compounded semaglutide injection. Now, and I know it's not necessarily one-to-one comparison. It doesn't necessarily mean that because a person's taking tirzepatide injection, semaglutide injection is going to be just right for them. But there are some patients for whom that will be the case, and prescribers are making that judgment and transitioning them over there. So the only thing I think that might keep tirzepatide, Mounjaro and Zepbound not to be kicked back into shortage is these patients may be transitioned over to the semaglutide product until semaglutide comes off.
So I was purposely trying not to interject because you were so on a roll. And I could see the passion that you have. And I think the recent article you had with Eli Lilly was very good. One before, like that one, I really want to see your passion come out. You ready?
Was that the one where I quoted Buddy the Elf?
Is it They Sit on a Throne of Lies?
Yeah, that's a quote.
Buddy the Elf.
Funny movie Elf.
Oh, that article sparked a lot of important conversations. And for us, and for me, this article paints like this vivid picture of the challenges compounding pharmacies face, particularly with pharmaceutical industry's attempts to misrepresent our work. And you do such a great job of calling out their tactics including conflating compounded medications with counterfeit drugs and making unsupported claims about safety. Could you please expand on why you believe that taking this approach and how it impacts patient care? And yeah, like I said, feel free to get more.
I am one of these people who I like precision in syntax, and so saying that someone lies is a pretty strong assertion. Sometimes people can just be mistaken. They could misspeak. But saying that the drug makers, and again, it's a funny quote from the movie Elf, sit on a throne of lies is not hyperbole. They are purposely misrepresenting, mischaracterizing pharmacy compounding, and attributing safety concerns that don't exist. And so the purpose of that opinion piece was really to delineate, I guess, the range of stuff that the drug makers had done. And the drug makers, Eli Lilly and Novo Nordisk. We've had cease and desist letters against pharmacies that are just a fusillade of crazy claims that do not comport with what law and regulation say, but are designed to intimidate, I believe. And those cease and desist letters have gone not only to pharmacies, certainly some have gone to med spas, they've gone to telehealth platforms, but they've even sent cease and desist letters to prescribers of compounded GLP-1 drugs, which I think is kind of ballsy. And again, it's an effort to intimidate. They have sent letters to patients, Eli Lilly has, who, and who knows how they got the data, but they have determined that patients were taking a compounded tirzepatide injectable, and Lilly has sent letters to those patients saying, we would like access to your medical records to determine if this is appropriate. And Eli Lilly's CEO said that it was part of their strategy to use threats and intimidation to try to stop the compounding of the tirzepatide API. There have been a number of actual lawsuits against compounding pharmacies. Some of those against med spas, frankly, have had validity. There were a number of med spas that were making claims about compounded drugs that they shouldn't have been making. I mean, you can't pair a compounded tirzepatide or use the name for a compounded drug associated with the brand name. So there's no compounded Wegovy. There's compounded semaglutide, but not compounded Ozempic or compounded Zepbound. Neither are compounded drugs generics. You can't call them generics. They're not remotely generics. And so some med spas were doing that or alleged to be doing that, and they ended up having to settle with the drug makers because of those claims. But there were other lawsuits against compounding pharmacies that were simply filed. It's strange to me that these behemoth drug makers are filing lawsuits against mom and pop pharmacies, but they are, because the pharmacies are preparing kind of versions of their drugs. They have touted supposed adverse events associated with compounded drugs and suggesting that the numbers are extraordinary, when in fact the number of adverse events associated with the FDA-approved GLP-1 drugs are exponentially higher than those reported for compounded versions. And when you compare the adverse events for compounded versions versus the FDA-approved drugs, they are remarkably similar. Again, any serious adverse event needs to be investigated, needs to be taken seriously. One of the interesting things that a lot of folks don't know, but on which the drug maker is relying in making these claims about adverse events, is that FDA's adverse events reporting database is a record of reports of adverse events, but it is not definitive. FDA does not go out and determine that the drug in question actually caused the adverse event. So there's no causation there. And the drug and that goes for FDA adverse events reported for FDA approved drugs or for compounded drugs. So they've misused the data, maybe misunderstood the data. I don't think they've misunderstood it. I think they've misused it. They touted dosing errors with the vial and syringe system that compounders use, and yet that vial and syringe system has been used for decades for insulin and a range of other things that they don't seem to have too much interest or concern about dosing errors with those. And so it's just a range of legal strategies and intimidation designed to I think strike fear in these small business pharmacies that are meeting a need for a life-changing drug at a time when these drug makers cannot meet that need.